Life and Breath Foundation speaker series. We're going to give an opportunity for you to ask questions at the end of Dr. Raj's presentation. In advance of that, we have maybe 25 questions that were given to us in advance. So we've kind of put those into the presentation, and we're going to be able to talk through a little bit of that. And then we'll have some time at the end for some additional questions that you can submit if you like. Please use your Q&A option at the bottom of your screen to be able to do that. And we'll circle back with you as we walk through it. I guess where I'll start, Dr. Raj, if you want to present your screen, I'll tell you a little bit more about.
Oh, sure. I mean, I always love this picture. Wow. Thank you, guys. That is a very big picture of me.
Good stuff. So, Doctor, could you share your screen, and then I'll...
Oh, you can't see it? You can't see my screen?
No, I can't see it.
Oh, no, why? I think I'm being, I think you're right. I'm kind of a mean person. I'm not sharing screen. I was like, we had a little awkward silence.
We always would love to share.
All right, here we go. Everyone, that is my fault. I did a poor job with Zoom over here. You could just give it to me. All right, how's that?
All right, there you go.
And okay, now there's me over there, and let me. You want me to go?
Slide two.
Want me to go back right here?
There you go.
All right, now we're good. Now we're good. Here we go.
We're all good. So again, just wanted to welcome everybody to the Life and Breath Foundation Speaker Series. We're very proud to be able to host this opportunity to bring in some of the nationally known authorities on sarcoidosis. First, I want to tell you a little bit about the Life and Breath Foundation. My name is Sean Hall. I am the president and founder of the Life and Breath Foundation. The Life and Breath Foundation was created in 1998 in memory of my mother, Ida Hall, who passed away with sarcoidosis in 1996. The family did not know that she had the disease. We think she struggled with the disease for 13 years by herself. And I knew I wanted to do something in her memory. And I only could imagine many patients who suffer and have the same type of questions that maybe she had in trying to understand how to manage this disease, how to interact with physicians and doctors, and how to understand exactly what the medications are. So we've been fundraising for patients with sarcoidosis for a little over 22 years. As you can imagine, this year has been a challenge with the COVID-19 struggle. Both of our fundraising efforts this year, the events that we had scheduled were canceled, so that we looked at how can we still play a part in helping patients this year, especially in 2020. So that's where the speaker series has really evolved. We've had quite a few people come on, gifted, talented authorities on the disease. And I would not be able to do this by myself. I have the luxury of having a very supportive committee that helps me put together a lot of these different efforts. But what I wanted to let you guys know about Life and Breath Foundation, our primary goals are to offer the sarcoidosis community effective tools to track their journey, decipher their medical issues, and maximize their quality of life. We are also interested in providing a nurturing environment for those affected by sarcoidosis could share their experiences with others, helping those other people understand that they're not by themselves. We know it's a mystery disease. We know there's some question marks. We know that it affects different organs in different ways, but you're not by yourself. And we hope to build more awareness within the medical community to help combat this chronic disease. You can find out a little bit more about us at the following things that are listed there with our social media and our website. But one of the more important things that we wanted to do is, again, introducing the national speakers that are going to come and really share a little bit more. What I'd like to do is tell you a little bit more about our speaker this this evening. Dr. Raj Dusgupta is a pulmonary critical care and sleep medicine specialist. He's a USC professor, author, and media personality. He's a quadruple board certified in internal medicine, pulmonary, critical care, and sleep medicine. He completed his internal medicine residency at Michigan State University, pulmonary and critical care fellowship at Columbia University, St. Luke's and Roosevelt Hospital, and sleep medicine fellowship was at the Henry Ford Hospital. Currently, Dr. Raj is a professor at the University of Southern Cal and received the Faculty Teacher Award for the last 6 consecutive years. He is the author of Medicine Morning Report, Beyond the Pearls. Currently, Dr. Raj is on various media platforms and television shows, including Chasing the Cure, The Doctors, CNN, and Inside Edition. I've listed a couple different ways you can connect with Dr. Raj on social media and his website, but more importantly, I'd like you to sit back and allow Dr. Raj to talk to you a little bit more about our topic this evening, which is sarcoidosis medications and the side effects. Dr. Raj, the floor is all yours.
Oh, thank you, Sean. And once again, that was an awesome intro. And I definitely want to say thank you to Life and Breath Foundation. When I first heard about you, and Sean, I heard about your mother, I just love the story. I love what you represent. And I think it's always good, especially around this time, to just have positive vibes and positive feelings for everyone. So thank you for letting me be here. And I am truly excited to actually talk about my favorite topic in the whole world, which is sarcoid. And, you know, I think, Sean, you're almost a sarcoid professional in yourself, because everything you said is right. There's big question marks, you know, and when we talk about treating sarcoid patients, you know, there's not one way to do it. And I think that's what I do like about sarcoidosis, is that it's not just there is a roadmap that you follow, is that it's very individualized to each patient. And because of that, there's not enough time in here to talk about everyone's medications. You know, I would love to do that. But what I felt would be the best thing is that, you know, talking about what are the medications, what are the dosing, and especially the side effects. Because if you were to ask me, I mean, how do I pick my medications? You know what? I look at the whole picture. I look at your kidneys, your liver, your other drugs. What could you tolerate? And of course, let's be honest, what can we afford? And you know, so all these things are going to be factoring in, okay? So put a couple of basic sarcoid slides, because I think, you know, when I choose my medications, there is some science behind it. So, you know, what causes sarcoid? The answer is, I don't know. I mean, I wish I did, you know. Is it environmental? Is it some kind of, you know, infection that started it all? Like things like tuberculosis or fungus, but we really don't know. And that's why in this slide, you know, what triggers it? It says unknown antigen. But, you know, the medications that we're using for sarcoid are really geared on our immune system, because that's what sarcoid does. It really dysregulates your immune system, meaning that inflammation goes up, anti-inflammation goes down. All those are bad things. So we talk about our immune response. And I don't want to get very basic science, because you will start sleeping. But when we talk about our immune response, there's 2 parts of it. There's our innate immune response, and those are things like our skin, the acid in our stomach, or there are certain cells in our airways that interact with the environment. That's called our innate immune system. And the other part of the immune system is the adaptive. And that's when we talk about things like T cells and B cells, both of which are lymphocytes, and all these things are going to be interacting with each other. So notice that what causes, you know, the end product that causes all the damage, the things that we're afraid of, are these, which are non-casein granulomas, is this immune response. And I put a bunch of different cells here, not to quiz you medically, but to show you that when we choose our medications, we're trying to put your immune system back together again to decrease inflammation, increase, you know, those anti-inflammatory cells. That's the whole purpose of it. So when we think about these non-caseating granulomas, well, 2 main things can happen to it. The most common thing that happens is, you know, spontaneous resolution. And, you know, and that's going to be most of my patients who have sarcoid. You know what my patients are. They're initially told, you have cancer. or you have a horrible infection. And there are just, you can imagine the stress, the worry. But then after the workup, they're like, well, it's not cancer. Well, what is it then? Well, it's sarcoid. And for a second, you're happy. Then you start reading about it. And you're like, what is sarcoid? And it gets, and the big thing about it is that even though you carry this diagnosis, most individuals will have, resolution and do well. But there are people that go on to nonstop inflammation. And depending on when the sarcoid is, because Sean said it correctly, it can involve any organ in the body. Sometimes it can cause, real bad organ damage. So when we talk about, I kind of set myself up here, what organs can be involved? The answer is all of them. I put this picture of a chest x-ray here because many people who come to sarcoid don't have symptoms. And you get this chest x-ray finding that we call bilateral hilar fullness. The hilum is just this area in the circles, and it's full because we know those turn out to be lymph nodes. And we know that sarcoidosis can really make those lymph nodes really big, right? And when we talk about the most common organ involved in sarcoid, it's always the lung. But let me quiz everyone listening today. Who can tell me what is the second most common organ involved in sarcoid? Who can say it? I know, I wish it was a live lecture, huh? But the second most common organ is always the skin. Exactly. I heard someone say it. Good job over there. So, but if you were to ask me, what are going to be the 3 organs that no matter how serious or not serious that I always, always, always treat? There are 3 organs I always want to treat. Number 1, who wants to guess? That's right, the eye. No one wants to be blind, trust me. So whether it's uveitis, whether it's going to be retinal vasculitis, all these things, you definitely want to be aggressive and treat. What's the second organ I always want to treat? That's right, the heart. It's not good to have heart involvement. I'm very aggressive. And the third one? Yeah, up here. It's going to be the central nervous system, the brain. So when I see most of my patients, I always want to evaluate, do you have involvement there? Because I will be more aggressive. Even though the most common organ is the lung, I don't always have to treat the lung because you may just be asymptomatic, and the main reason I just don't treat everyone is because sometimes, when I treat, and let's just say the word now, steroids, that would be a whole new set of problems. So when you see your doctors for sarcoid, the first question they should always be asking is, do I even need to treat? Okay. Now, with that being said, I wanted to put this slide here because this is a general treatment outline. So when I see you for the first time, in my mind, I'm going to put you in one of these 4 categories. Are you asymptomatic, acute, chronic, or advanced? So, if you're going to be asymptomatic, well, I think the answer is no therapy, right? That would be weird to just give you steroids for no reason, except if I see the eye, the brain, or the heart. Then that's a whole different story. But most of the time, I'll just kind of monitor you. And if I want to do like some doctor talk, I call it active surveillance. And we do that in some patients. Now, if you get a flare of your sarcoid, we're going to call that word acute sarcoid. And what do we give for acute sarcoid? That evil word, huh? Steroids. And steroids have different names: prednisone, dexamethasone, solumedrol, hydrocortisone. And the side effects of steroids are like, what, this much? You know what I mean? And we'll talk about those side effects coming up. But the only other drug, just to mention, that someone may have used for acute sarcoid is something called cyclophosphamide, Cytoxan. Now that is a real toxic drug, and I haven't used that drug in quite some time, but I just wanted to mention it. But most of the time, the drugs we use for acute sarcoid are going to be those steroids over here. If you have chronic sarcoid, and I'm imagining a lot of people listening today have chronic sarcoid, it means that you're on steroids, you're still having symptoms, or they can't get you off the steroids itself. And what we do is we add, now this is a mouthful, non-biologic cytotoxic agent. You know what? Let me just say, we call these DMARDs, disease-modifying anti-rheumatic drugs. The reason they're called anti-rheumatic, because a lot of the drugs that we use for sarcoid were really used mainly for rheumatoid arthritis or lupus or these rheumatological diseases. And I wouldn't be surprised if someone listening today has a rheumatologist that really manages their sarcoid, because a lot of these drugs are really used in the rheumatology field. So what are going to be some examples of these DMARDs that are non-biologic? Let me throw out some names. Methotrexate. Yeah, I heard someone shake, did the head nod right now. I saw it. Imuran, Celsep, Hydroxychloroquine. I mean, there's so many of these drugs, and we'll go over them today. And usually most patients may stop at this point because we're trying to get you off the steroids, we're using these DMARDs. But if you're still having symptoms, then unfortunately you go on to advanced sarcoid. And this is mainly when they see someone like me. And if I didn't get to mention it, I run the Sarcoid Center here at the University of Southern California. And it's one of my favorite things to do is to interact with sarcoid patients. And one of the things, some of my weapons I use for advanced sarcoid are these biological DMARDs. We call them TNF inhibitors, and we'll talk about them, and I'll give you some names so you know what I'm talking about. Remicade, Humira. So those are going to be these biological DMARDs. And over here, there's another drug called Acthar, and it's another option. So one thing I wanted to do is kind of mention some other options that are not common, so you can get some take-home messages and advice from this conference. So with that being said, I said for acute sarcoid, the mainstay therapy is steroids. And how do I describe steroids? A very, very smart pulmonary doctor once said this joke to me, and they said, Raj, when patients come see me, I diagnose them with sarcoidosis, and after I treat them, I give them a new disorder. I'm like, which one's that? It's called steroidosis. And I loved it, and that really summarizes what steroids do. You need them, but they have so many side effects. So I just want to quickly go over what we see here. And, of course, steroids, they suppress your immune system, and you need that. And of course, right now, it's hard to blast people with steroids because, say it, COVID-19, you know what I mean? But if you're having a flare, it's going to be steroids because they're very rapid acting, and they're going to get decrease that inflammation. What about this? Hyperglycemia, isn't that kind of the fancy word for high glucose, poorly controlled blood sugars? And who out there listening today? And let me put my thing up there. I heard I think like 45, 50 people are listening. That's impressive. Who has diabetes? Who has type 2 diabetes? I mean, a lot of people. My family has diabetes, and you give steroids, and what happens to those blood sugars? They go up. This bullet point here is, when you give steroids, even if you give it like inhaled steroids, who's got easy bruising of the skin? And look at this, what I put right here. Who gets these little marks down here? That's a lot of people, Oh, Alexis, did you raise your hand? Oh my God, I love that. You're getting into it, So you're getting some easy bruising, and it happens everywhere in the skin. And, unfortunately, as we get older, you have to worry about that bone health. And, I'll tell you one thing, that when we talk about sarcoid, I know that we always say that in the United States, African Americans get it the worst, and that's 100% correct. But in my clinic, I see everyone. It's amazing. I have some Filipinos, I have some Indians, it's amazing how sarcoid doesn't spare anyone, you know what I mean? And when we talk, and males and females. So reason why I gave that whole spiel is because, when we think of osteoporosis, we always kind of think of females, which we should, and in the United States, we do screen for osteoporosis starting around age 60, 65. But if you're on steroids, you got to talk to your doctor about screening for osteoporosis with that DEXA scan a little bit earlier, And even men, that's right. Even men, if you're stuck on those steroids, you got to worry about bone health, And what about this one, everyone? Weight gain. It's already hard enough, not being able to move and trying to exercise in pain. And then you give some steroids, it causes you to have swelling of the lower extremities. And it's hard, and of course, if you already have diabetes, that's not helping it either. And sometimes if you have doctors speaking doctor talk, you may look what they call Cushing-like. And Cushing is actually, a name of a, when you have excess cortisol steroids in your body, you look very Cushing-like, Now, these two, I always want to mention that steroids definitely affect those eyes. And for patients with sarcoid, they already, sarcoid already can affect the eyes. And now when you treat it, it could cause more problems with the eyes. I always want to worry about glaucoma. I want to make sure you guys think about cataracts. Cataracts is when, the lens of the eye gets very, very foggy. I mean, you don't want to lose your sight. And then these last couple is, depending upon how long you're on the steroids and what dose, you can get psychoses, euphoria, You could get muscle weakness. And the key thing is no one ever cold turkeys the steroids because there's something called your adrenal gland and it naturally produces steroids. And if you stop the steroids right away, your adrenal glands need time to recuperate and they can't do it. And that could cause a whole new set of problems. So, steroids, we need them. If you come to me in acute sarcoid flare, I'm probably going to give you steroids, but, they definitely have their side effects. So what do we do to help you not get these flares? What do we do to help taper down the steroids? We use these non-biological cytotoxic agents, otherwise known as steroid-sparing agents. And, it's unfortunate that there are very few drugs out there that got FDA approved for sarcoid in itself. Many of the drugs that we use, like I said earlier, have been FDA approved for rheumatoid arthritis, lupus, many other diseases, and we're just kind of using a lot of observational data. So I wanted to say this. So when we talk about sarcoid and we talk about any disease, what do we really want? We want, evidence-based medicine. And to get that, it's tough because it's always going to be a combination of getting the research, clinical expertise, resources. This kind of sounds like a COVID-19 talk, doesn't it? But it's the same thing when we talk about, sarcoid. And that's why when we choose these agents, which are not FDA approved for sarcoid, you want to have clinicians and people in the healthcare profession that have that clinical experience and are familiar with what research is available. So one of the most common drugs, and I got to tell you, this is my go-to, is methotrexate. Methotrexate's been around for a very, very, very long time. Initially it was used for some malignancies. We definitely use it for rheumatoid arthritis. And one of the reasons why I like it is it does have a good track record. And for my patients who are on it, how many times a week do you take it? Once. I love it because compliance, So, when do I like to give methotrexate? On Monday, methotrexate Monday. It begins with the letter M, so you'll never forget to take it. Now, methotrexate, when we dose it, we don't use it at the higher dosing like with rheumatoid arthritis. I think it's around 25 milligrams weekly. I'm more of a 15 milligram weekly type of guy, maybe 20 milligrams weekly. You always have to take folic acid daily because that's the way methotrexate works. It inhibits this enzyme here called dihydrofolate reductase, which means that if you don't give the folate back, you can get some really, really bad side effects. So that's why many of you take things like folic acid 1 milligram daily. But methotrexate, once again, does have its side effects. I slowly titrate up the drug. Usually I start at 7.5 milligrams weekly. For those who take the drug, it comes in 2.5 milligram pills. So you'll probably start off with 3 pills and then you'll slowly go up. And the reason why I titrate up slowly is because it gets a lot of stomach side effects. You can feel nauseated, you could have some vomiting. So I really want to go slowly to make sure you can tolerate it. So I increase the dose by 1 pill, 2.5 milligrams, until I get to my goal around 15 to 20 milligrams. Someone out there would say, you know what, doctor, I'm taking it as a shot intramuscularly. And it's true. Some people do that. And sometimes, if you get a lot of the nausea and the GI side effects, to bypass that, we'll give it as a shot. Now, I don't usually prescribe it that way because I'm just a nice guy. I don't want anyone to do that. But don't be surprised if you're having those side effects if it's prescribed in that way. Side effects I want to mention, I would say you want to be careful about the liver, meaning that, hey, I'm sure there's someone out there that loves a glass of wine before they go to bed, but you want to be careful with alcohol. You want to make sure that you're hepatitis B and hepatitis C negative before we start the medication. And there's certain things I'm going to follow as a clinician. So I'm sure people on the drug who are listening today, their doctors would like to get a CBC, a complete blood count, to make sure all their white blood cells, red blood cells, and platelets are okay. And periodically, you may want to get like a liver panel to make sure the liver is doing well. So this is a very, very common drug that I would use if you have chronic sarcoid, where I'm going to use it as a steroid-sparing agent. You would give it weekly. And the key thing about this med and many of the meds that we use for sarcoid for chronic, that they don't work right away. They take almost 2 to 3 months to actually get to its maximum efficacy. And it's important to tell patients this because, you take the pill and, like many people, okay, what happened? I'm not feeling any different. And you've got to get that reassurance from your doctor to let you know that it's going to take a while. And hopefully by being on this medication, you could taper down the steroids and prevent getting those flares. So if you're getting a flare of sarcoid quite often, I definitely think you would be a candidate for a disease-modifying drug such as a methotrexate. But of course, if you have renal failure, this is not the drug for you. Liver failure, this is not the drug for you. So that's why you need a doctor to kind of look at the whole body. Now this one, it goes by the brand name Imuran, and many patients may be on this medication. It is an alternative to methotrexate. Some doctors, who manage sarcoid like this as a first-line drug. That's not wrong at all. This drug is a weight-based drug, so I need to know your weight. I don't need to know it right now. You can keep it to yourself. It's okay, but it's a weight-based drug. But I usually start around 50 milligrams, and probably for most of my sarcoid patients, they're probably going to be around on a 100 milligram dose or 150 milligram dose. And one of the side effects, you probably wouldn't notice them while you're taking the med. If you do, would be probably some nausea, some GI upset, but we do have to follow labs while I'm titrating up the dose. And very similar to methotrexate, I like to get a CBC, a complete blood count, to see how your blood products are doing. And I like to check your liver too. So this is going to be a brand name Imuran, which is another alternative to methotrexate. The main difference is methotrexate going to be once a week, which I love. This is going to be a daily medication that you need to be on. And maybe if you fail methotrexate, that maybe I'll choose this medication. Or if you fail this medication, I'll choose methotrexate. This one I'm going to kind of breeze through pretty quick. This is called leflutamide. It goes by the brand name Arava. And this is kind of like the brother of methotrexate. It works very similarly in a very similar pathway. And usually, I would say I would consider this drug where if you're on methotrexate, and it seems odd that methotrexate is such a commonly used drug, it does sometimes have some side effects in the lung, go figure, but I rarely see it with sarcoid patients because I use lower dosing. But in theory, if you're on methotrexate and you do get some lung toxicity, like in a disease such as rheumatoid arthritis, this will be an alternative medication named Arava, generic name leflutamide, and you do take it daily versus methotrexate, which is weekly. I have to tell you that not many of my patients with sarcoid are on this medication, but just to be complete, if anyone's out there, I just wanted to acknowledge that this medication, Arava, exists. Hydroxychloroquine. I'm sure I see many smiles in the audience. I always start off this by saying, I didn't think we had any hydroxychloroquine left in the country. I thought it was all gone, but and so I got to tell you, when this came out, I went on the news, I went on my media platforms, and I really just truly said that my heart really went out to the patients with lupus, patients with sarcoid, because it was really tough for a lot of patients out there to get this drug at a certain time, and it was really frustrating. So hydroxychloroquine, if you're a lupus patient, you should be on this drug. I mean, this is the mainstay drug for patients with lupus. But for sarcoid, it's a very weak anti-inflammatory. It's not that strong of an anti-inflammatory. I use it in sarcoid patients if you have elevated calcium in the blood. Sometimes if you have sarcoid of the skin, I may consider using that. But in itself, what are some of the side effects of hydroxychloroquine? Well, if you take it long term, I'm sure your doctor will tell you that, you got to go see an eye doctor because it causes retinal damage that's irreversible. And once again, I wanted to remind everyone that this drug is actually weight-based. And the reason I'm making a big stink about it is, sometimes I've seen patients are just placed on the drug because they just want to, doctor said, go on the drug. And it has to be based upon your weight. So many people are on 200 milligrams twice a day, so it really depends. A couple of things I wanted to mention is that I mentioned the eye toxicity. So even though all sarcoid patients out there need to see an eye doctor, if you're on this medication, I'm not going to cut you any slack. You definitely got to go see that eye doctor. But, on the news, they're always talking about, arrhythmias and QT prolongation. I got to tell you, everyone, that I have never seen this QT arrhythmias with hydroxychloroquine by itself when it's used in the right patient. Of course, if you have heart disease and you're taking azithromycin and you're on hydroxychloroquine, and in these studies for COVID, they were giving really high doses, sure, I can imagine that. But I think for most individuals, if they're on it, it's not a potent anti-inflammatory. Be sure to follow up with your ophthalmologist. And maybe you're on it because of skin issues, or maybe you're on it because your calcium tends to be on the higher side when we talk about sarcoid. Now, here's another one. This is another one of these disease-modifying medications. It goes by the brand name Cellcept. Anyone on Cellcept? I'm sure one person is, you know. So when we talk about Cellcept, you know, there's a lot of data about this. Oh, I love the hand. Wendy, I saw your hand raise. I'm digging it. So when we talk about Cellcept, really a lot of data for a lot of rheumatological diseases. Carla, I saw your hand raise. Good job. So the data for it in sarcoid is not going to be as robust, but you know, it's definitely a reasonable drug to go on. It's an alternative to Imuran, an alternative to Methotrexate. It definitely is, once again, based upon weight, and we go up pretty high on the dose. So I'm going to guess for the people who raise their hand, they're on probably, you know, 2 grams of Cellcept. Sometimes we go up to 3 grams. That's 3,000 milligrams of Cellcept. You'll be surprised how high we bring up that dose. It does cause a lot of GI side effects. So when I'm titrating up the dose, I always like to have my patients call in if they can't tolerate it. But the answer from almost every drug is always go slow. You know what I mean? And just like Methotrexate, Imuran, you know, Cellcept doesn't kick in right away. You don't take one dose and you get the benefits. It really takes a while to hit its stride when we talk about it. And I put down here Myofortec. So as one of my little pearls I give to my patients, if I really decided that you need to be on Cellcept and you're having a lot of toxicity from the medication, let's take a step back. If you're on Cellcept, we decided that, and you're getting a lot of nausea and diarrhea, but really you're getting clinical benefit, there's another brother of Cellcept called Myofortec. You know, it's pretty much the same core drug, and I may try that because sometimes a few of my patients would say, hey, you know, Myofortec worked for me a little bit better, or vice versa. You know what I mean? Maybe it's not going to be Myofortec, maybe it's going to be Cellcept. But take-home message is ask your doctor, because he or she will definitely, you know, have these, you know, recommendations for you. Now we're getting to some of the big guns over here. So this medication is called Rituximab. So Rituximab is going to be an IV infusion. So when we talk about Rituximab, and the way it works is that Rituximab really works on some of those lymphocytes, some of those, you know, which are types of white blood cells that are part of your immune system. And usually what we do is, if we decide to go on this medication, I usually save it for patients who have that advanced sarcoid. It's not a very common medication that I use. And this drug has been used for many rheumatological diseases. I'm sure someone out there knows someone with rheumatoid arthritis that's on Rituximab. It's common in the rheumatological field. If I decide to use this for a sarcoid patient, well, I got to load you up first. You get an IV infusion, you know, and I'll do that on day 1, and then I'll do it again on day 2 weeks later. And then for most of my patients, I'll dose it every 6 to 12 months. That's going to be based upon your response. Like, wow, I really felt benefit, or things may be going the wrong way. We might have to step up the therapy. And I would say for most individuals, you know, I haven't got it myself, that it's tolerated really well. So, you know, I think the take-home message is that, you know, discuss with your doctor if you have advanced sarcoid. And some people, you know, don't want to take daily medications. They don't want to take weekly medications. And if this is something that was offered to them, that they could get an infusion once every 6 months or 12 months, this may be reasonable for him or her, but it's not a very common medication that we use in all patients. And I'll probably only start thinking about that once you have more of the advanced sarcoid. Now, this is the broad category of drug. We call those TNF inhibitors. TNF stands for tumor necrosis factor inhibitors. And when we talk about them, there are really a bunch of them out there. I only put 2 because the most important thing is these are the only 2 that really have shown benefit when we talk about sarcoid patients. So when we talk about these medications, a couple things. Number 1, remember that first slide I showed you? You know what? Right here. Boom, look at me. This is advanced sarcoid. This is when we think about these TNF inhibitors. this is when we think about rituximab. So we're going to be down here right now in the advanced sarcoid. When I'm here in the chronic sarcoid, this is going to be the methotrexate, the Imuran, the Celsa, the hydroxychloroquine. They're going to be up here, these non-biological cytotoxic agents. So now that we're down there, this is something that we can discuss. And, to be on these medications, a couple things need to be ruled out first, So number one is that we've got to make sure you don't have things like tuberculosis. So they're probably going to ask you, and I'm sure many people have done this, they need to get tested for what we call latent TB, which is also known as sleepy TB. Like you don't have active TB, and if you do have latent TB, we need to treat it before we start you on many of these medications like rituximab, like TNF inhibitors. And that's why I drew this little thing here. You remember, I don't know if anyone remembers, the way we check for latent TB in the, I hate saying this, I apologize, in the olden days, is we do what's called the PPD. Nowadays, we use what's called a quantiferon gold, which is just a blood test. It seems to be a little more convenient for many people out there. And if you are latent TB negative, if you don't have hepatitis B or C, then we would consider using these medications. The thing that many doctors will tell you is that, these medications, what a surprise, they really suppress your immune system. So we really don't want individuals to get sick when they're on these medications. So we definitely inform you, and we definitely worry about trying to avoid, and it's not easy, getting bacterial infections, getting viral infections. So Remicade, everyone, I know we got a lot of questions about it, is given through the IV. So you have to go to an infusion center. Humira goes by the brand name adalimumab, meaning that's an injectable drug. And I'm not saying one is better than the other. And, in some cases, I may start with one. And if, he or she doesn't respond to it, I'll switch to the other or go back. But the key thing is these are the only ones that really have good data for sarcoids. So if you see commercials for Enbrel, commercials for Simponi, I really would talk to your doctor and say, hey, is this the way you want to go? These are the only ones that I use for my sarcoid patients. And, when we talk about another medication, it's called Acthar. And this is a medication that's been around for a very, very long time, but it was approved for other diseases, whether it's going to be lupus or even things like multiple sclerosis, and I'm already going to imagine there's someone listening today that probably has multiple sclerosis because there's that overlap sometimes of, unfortunately, people with sarcoid getting misdiagnosed or vice versa. And this medication is injectable, and it works on your immune system. So it works on a receptor called a melanocortin receptor and all these immune cells over here. And it's something to consider. When would you consider something like an Acthar? Well, you know what? Let's go back. It's going to be right here. When you have the advanced sarcoid patient, you've already been on steroids, you can't get off. You're on your methotrexate-like drugs, and you're still having symptoms. Well, then you would think about rituximab, TNF inhibitors, Acthar. So these are things I hope that some people didn't know, so you could have more questions to ask, or to see if you're a candidate for these medications by talking to your doctor. So, behind the scenes, I was telling everyone I want to give, some new information that makes me happy for my sarcoid patients. So I put this slide, what's new? So there's been a medication called Ofev over here, and its claim to fame was for a disease called pulmonary fibrosis. And, what it does is when you have pulmonary fibrosis, it really is a horrible, horrible disease, and I wish it upon no one, and certain people have what's called IPF, idiopathic pulmonary fibrosis, And this drug actually has been shown to reduce the decline in lung function. It does have a lot of side effects. I'm never going to lie to you, everyone. There is a lot of side effects. You don't feel better on the drug, but it slows the decline in lung function. So why am I bringing it up today is that based upon recent studies, this medication did get FDA approved for patients with sarcoid who have fibrosis in the lungs. So I thought that was a nice thing. And I'm not telling you to run out there and buy up all the Ofev. What you need to do is talk to your doctor, and just say, hey, can you go over that side effect list? You know what I mean? Because it's pretty long. And I'll be the first one to tell you that, many people don't tolerate the medication. And the way it's working is that you have to check your lung function periodically, and it slows down the decrease in lung function. And once again, to make sure I don't misspeak, it's only approved for if you have sarcoid where? In the lung. And not just in the lung, but you have to have fibrosis where? In the lung. So it's only for people with fibrosis in the lung who have sarcoid, and it's something you could talk to your doctor about. So that's what's new. That just happened. And with that being said, I promised everyone I'll look at the time because they said I have to, answer some questions. So these are some of the questions that we have. I'm going to whip through these, and I'm going to give you guys and gals some time to blast me with some questions, okay? So questions I got already. What is the best thing to do for joint pain and spasms? Well, no one should be surprised that sarcoid can affect the joints. It can cause an inflammatory joint disease. And if they are, a lot of the medications that we use for rheumatoid arthritis will give you some benefit in sarcoid patients. And the classic example is going to be things like methotrexate. We use that for rheumatoid arthritis. But let me just say this. The hardest thing about sarcoid, and I'm sure everyone's going to agree with me, is that it mimics so many different things. And when someone comes in and they say something like chest pain, they say something like fatigue, my joint pain, my patients look at me and say, Dr. Raj, is it my sarcoid? And you know what I'm going to say? I guess, because you don't know. It's so hard. And that's why sarcoid patients are so frustrated, because you never get a straight answer, because it's really hard to know if it's going to be sarcoid or not, because your joint pain could be things that are common. Like what? Osteoarthritis. Who has osteoarthritis? I don't, but I'm just saying, it could be common things. So it's really hard to do that. And raising the hand, I love you guys and gals. So I would say, I hate to say it, you have to have faith in your doctor. You need to talk to him or her and, have the evaluation to see if your sarcoid is flaring or not, because it could be a common thing. I like bullet point number 2 quite a bit because, vitamin D is a very important thing to have at normal levels, especially African Americans. You need to have your vitamin D at a normal level. And especially with all the research done with COVID and vitamin D that are out there right now. So the big thing is that everyone knows that sarcoid patients are really predisposed to having high levels of calcium, right? So people are scared to take their vitamin D. But no matter what, I would say that you should check your vitamin D level. I don't want to get super medical. It's called a 25 vitamin D. That's the one we look at. There's a normal range. I would say don't let that one slide. If your doctor doesn't feel comfortable managing your vitamin D, you should go to a rheumatologist. You should go to an endocrinologist, because vitamin D deals with calcium. And what did we say earlier today? Osteoporosis, osteopenia, bone health. So I would say that if you have low vitamin D, and vitamin D is something where, it's not just, hey, take some vitamin D. There's really some science behind it based upon your age and weight and gender. All these things factor in when we talk about giving you the right level of vitamin D. Number 3, what is the best way to deal with a sleep problem? Now, I think someone slipped that in there because they found out I was a sleep doctor. But I got to tell you, when I think of sarcoid patients, sleep and sarcoid don't go together. I think everyone's going to agree. Why are many patients with sarcoid having trouble sleeping? Well, I'm giving you too much prednisone. Or how about weight gain? How about people who probably have obstructive sleep apnea and are too scared to get diagnosed? Because if you see me, what I'm going to give you, and I'm going to put that mask on your face, and now you're really not going to like me, And, what about just stress? How many people with sarcoid have stress, especially during like COVID-19 times? It's just like all these things are coming in. So me and my sarcoid patients with all these things factored in, I'm not surprised. So there's really not a good way to handle it, but I'll tell you the wrong way to handle it. The wrong way to handle it is just, hey, give me some drugs. You got some sleeping aids? Going to the store and getting Benadryl. You know what I mean? That's the wrong way to handle it, because, even something as common as insomnia, you want to see what the underlying cause is, and you want to make sure you address it. And maybe the answer is, if someone out there is on a water pill like Lasix, maybe not taking it at night. Maybe you're having a lot of heartburn because you're eating late at night because you're on the steroids, and steroids make you hungry. So the answer is, please talk to someone before you just start taking a sleeping pill, because that's the worst idea. And the last one is the best remedy for a cough. And, my heart goes out because, when we talk about the most common organ involved with sarcoid, it's the lung. And what things can occur in the lung? Of course, yes, shortness of breath, but you can get chest pain that no one knows why. And I'm sure there's someone out there that says, you're right, Dr. Raj, I have chest pain. Every time I go to the hospital, they do an EKG and this, and they tell me it's not the heart, but I have chest pain. And I believe you, is because of the fact that people with sarcoid can get pain just from the sarcoid itself. And it's really frustrating because, I know doctors do a great job and tell you what it's not, but sometimes, including me, I do a very poor job in telling you what it is. So another part of that symptoms of what happens in the chest is that cough. And it's hard because of the fact that even though I can listen to you, your lungs sound clear, still you're going to have a cough. But what is going to be the answer is you do have to do your due diligence. That you have to see your doctor. Remember, common things are still common with sarcoid. So what are the 3 most common causes of chronic cough? 3 most common causes are heartburn, postnasal drip, or undiagnosed asthma. So I want to make sure some doctor really evaluated those things. Sometimes it could be medications for your blood pressure, and the big one is always an ACE inhibitor like lisinopril. So someone needs to look at that. So I just want to make sure that there's not a very common cause. And of course, if you're a smoker and you have a chronic cough, well, I'm not going to cut you any slack. Stop smoking, and of course, get evaluated to make sure you don't have lung cancer. But if the cough is from the sarcoid itself, it's really frustrating because, the patient's going to look at me and say, Dr. Raj, I'm like, yeah, are you going to give me steroids? And, sure, we could try it, but then all those side effects happen again. And they have to taper you off the steroids. So maybe one thing I do is maybe give you inhaled steroids. I'm sure there's 1,000 people now are going to say, yeah, my doctor gave me Symbicort or Advair, and, it's a hit and miss. And sometimes, we really try to do things because those medications do have an inhaled steroid in it. And truth be told, if I'm going to give you a steroid, I'd rather give it inhaled versus an oral pill that would really, really, really give you those side effects. So with that being said, it's 4:50. Sean, I'm ready, man. So if we have some questions out there, let's do them.
Awesome. We have quite a few that have come in, and I'm going to stay on that inhaled steroids question.
Sure.
What are your thoughts on Pulmicort?
Ooh, so, Pulmicort in itself is a inhaled steroid. It goes by the generic name budesonide. I love that you're putting me on the spot. I love it. So, I would say this is that, one of my little techniques into getting patients off, oral steroids is just giving the inhaled, because the inhaled steroids really stay in the lungs quite a bit. You don't get as much absorbed, so you won't get the waking as much, the diabetes problems. And that's one of my techniques to get you off the oral steroids. All these inhaled steroids, it's kind of a hit and miss. They all kind of work the same, whether it's going to be fluticasone or budesonide. So the answer is that if I do give it to my patients with sarcoid, it's either to get them off steroids or there's an asthma component. If I think there's an asthma component, the main therapy is inhaled steroids. Great question.
Gotcha. Excellent. So next question comes from Elizabeth. Are there any drugs that can be taken that don't cause immune system suppression during this time of COVID? My insurance stopped paying for Remicade, and I'm trying to get Humira approved, but would love to take something that I don't have to worry about getting sick also.
Well, Elizabeth, right? That was the name?
Yeah.
Elizabeth, that was a great question. That is the $1 million question. So it is unfortunate that, sarcoid, back to my first slide, is a disorder of the immune system. Because it's a disorder of the immune system, you have to use things that modulate it, where we decrease inflammation, increase anti-inflammatory. So unfortunately, that's what the drugs do. If you're already on something like Remicade, it's not, it's, you know, it doesn't surprise me that insurance companies changed their minds. All these drugs are very expensive. So my advice is please ask your doctor if you really like Remicade. There are things called biosimilars. Now, biosimilars did not get FDA approved for sarcoid itself, but, you know, they are usually a mimic of the Remicade, but like the name implies, it's similar. It's not exactly Remicade. If they switch it to Humira, it's just another type of TNF inhibitor. I think you might like it for one reason. You don't have to get infusions. It's injectable, which a lot of my patients like. But you're right, it is going to really suppress your immune system. Hopefully from the talk, what I could say is please ask your doctor to say, would I be a candidate for something like an Acthar? Now, I'll be the first to say, you know, for Acthar, you know, I do talk for that pharmaceutical company. And, you know, I do like it for one reason. It's an alternative to TNF inhibitors. It doesn't suppress your immune system as much, and you might be a candidate for it. So, but anytime we're talking about advanced sarcoid, whether it's going to be, you know, Acthar or TNF inhibitors or Rituximab, of course, you have to worry about immunosuppression. But let me say this, is that, you know, I don't know if I told anyone this, you know, my wife is a rheumatologist. And that's where all my passion and knowledge from rheumatology comes from. And what she tells her patients is, you know what, everyone's been asking her, should I get off my methotrexate or this during the COVID-19? She says, and the American College of Rheumatology says, no. Because if you stop these medications, then your immune system is really going to be out of control and you're really going to be a setup for failure. So please stay on your medications. If you are having side effects, you know what I'm going to say. Talk to your doctor.
Gotcha. Mm-hmm. Thank you, Dr. Raj. I have a couple questions that are relating to if you could how is each level of sarcoid decided?
Oh, wow.
Slide that has, you know, advanced, chronic, all that stuff. The question was, how is each level decided? And then the second part is, what exactly is advanced sarcoidosis?
Oh man, I gotta tell you, Sean, you got the smartest people listening. It really put me on the spot. So whoever asked that question, I'm gonna give you the Smarty Award today, okay? Because you're right. In that slide over there, these are just proposed general guidelines. See, it's an expert consensus. So this is not set in stone. No one chilled this out on Mount Rushmore. You know what I mean? That this is how one way to look at sarcoid. The reason why I put it here is because, you know, when I was kind of presenting this data, I really wanted to make it organized for your thought process. And I like this, meaning that most people don't need treatment. I think there are people out there. If you have a flare, you get steroids. If you are on steroids and still having symptoms, then you kind of move to chronic. And then I'll probably add on one of these methotrexate-like drugs. And then after here, you can make a squiggly line and say, that's kind of tough if you're still having symptoms after steroids and one other agent. And like someone previously asked, this is where things like Remicade, things like Humira, things like Acthar, things like Rituximab will kick in. And you can imagine those will definitely suppress your immune system. And most of those are given either through injectable or an IV of some kind. So this is just my way of kind of, you know, making the talk more organized. But great question. Great awesome. Question. Man. No one didn't let me slide with that one.
Oh, they're good.
They're good.
Yeah, exactly. So next question comes from Cheryl.
Okay.
Her question is, have any studies been done on sarcoid and MAC patients? 14 years ago, duo diagnosis, docs still never sure what to do with me.
Sure. So, you know, at first, I mean, great question. Let me let everyone know, everyone's probably, what is MAC? MAC stands for Mycobacterium avium complex. And did that answer anyone's question? Probably not. So what is MAC? Has everyone heard of tuberculosis? Good. So the full name for tuberculosis is Mycobacterium tuberculosis. But Mycobacterium is the name of the family, and there's many different types of Mycobacterium. There's Mycobacterium tuberculosis, Mycobacterium avium complex, which we call MAC. And MAC can actually have many different forms. So what happens is when you have really bad sarcoid lung disease, where you get what's called bronchiectasis, or you have cavities in the lungs, things like MAC could actually colonize, meaning they could live in that lung. And when you have MAC, it doesn't necessarily mean you have to treat. You have to take it in the broader clinical context. But because many, many patients with sarcoid have lung disease, and unfortunately that lung disease could be destructive, they could be colonized living with MAC. The reason why I don't just say treat MAC is because you need to be on 3 drugs. 3 drugs. You know for how long? Over a year. I know. And sometimes, you know, the treatment of MAC is worse than doing nothing, you know, and that's why it always has to be taken in what clinical context. So the hard part with sarcoid patients is always going to be, as I give you steroids and Rituximab and Methotrexate and Imuran and CellCept, that doesn't do good things to the MAC. So maybe a decision needs to be made that maybe we have to treat because you're going to be on such immunosuppression. So it's a very broad answer. And I mean, I tell you, I could come back and do a MAC talk in itself, but it is a very good question. There's not a one answer. And I would definitely want the opinion of an infectious disease doctor as well as your sarcoid doctor. Great question.
Awesome. Awesome. We're on a roll here. Next question from Carolina. She says, my white cell count dropped when I tried Arabia.
Oh, okay.
I am at the chronic sarcoidosis stage with immune system issues. Would Methotrexate be effective?
Wow, great question. So the answer is I would be very careful with Methotrexate because everyone, this is such a great question. Oh my God. This is Arava, this is leflutamide. And I said during the presentation that I don't use this drug very commonly. And how does this drug work? It's kind of like literally the brother of Methotrexate, meaning that they work very, very similar. There's more data for Methotrexate, but one of the things that Methotrexate does is because the way it works, it suppresses your bone marrow. And the reason why I would not recommend, in my opinion, of course, ask your doctor, you know what I mean, is not to go to Methotrexate now, is because they both could suppress your bone marrow. You know, it definitely has bone marrow toxicity in both of them. So I think I would pick something that doesn't suppress the immune system as much. And as you could tell, there are definitely other drugs out there that could be spoken about. And the last thing is that, you know, in itself, you know, sarcoid could definitely affect the bone marrow. I have many patients out there, and you could just raise your hand, where your white blood cell count is low just by having sarcoid, and your doctor may say that your lymphocyte count is low just by having sarcoid. So you got to be see, 2 participants raise their hand. So it's tough, you know, and with sarcoid patients, you know, you're darned if you do and darned if you don't, because it could be sarcoid affecting the bone marrow or the drug's doing it, but you want to avoid both doing it. So I think whoever asked that question, you got to have a heart-to-heart with your sarcoid doctor.
Definitely. Next question comes from Wendy. She says, how do we get rid of rheumatoid headaches and high blood pressure? I get headaches, high blood pressure 2 days later after infusion for 3 days.
No, well, the good news is that this is not a very common problem for other individuals, you know, and, you know, the reason why I'm addressing this is because, you know, my wife sees so many more rheumatological patients and prescribes these meds sometimes like they're candy, you know, and I have heard that before, but it's not common. And unfortunately, you know, these are things that you may want to micromanage with your physician, meaning that how fast are they infusing the medication? How frequently are they infusing the medication? Is there any role in pre-medicating with certain medications to help out when it comes to these headaches? So you're not alone, you know what I mean? For other people on this medication, it's not a very common side effect, but this is where, you know, I think a discussion just to make sure there's nothing we can do just to help out during those infusion days. And sometimes it's as easy as, like I just mentioned, slowing the rate, maybe a little pre-medicating. Good question on those.
Awesome. Next question is from an anonymous attendee.
Okay. Those are always scary. They probably want to get me or something.
You know it's going to be a good question. I frequently get chest and thoracic cramping. It can last for a minute or 2 to 20 minutes. It happens at rest or mild activity, etc. Any suggestions, comments?
Yeah, you know what I mean? Of course, my disadvantage is, I don't get to see you and examine you and all these kind of things. But, I will say, like I mentioned earlier, the stories that we're all frustrated with is that, if one of my patients says, chest pain, depending upon their age, comorbidity, do they have diabetes, we are bullied into saying things like, go to the ER. We are bullied into saying things like, you need to get an EKG. We are bullied into saying you have to rule out heart. But remember that one of the biggest mimics of chest pain and heart disease is heartburn, hence the word heartburn. So like I said, patients with sarcoid can definitely get chest pain. It's always going to be diagnosis of exclusion. I think we all want to play it safe and make sure it really isn't the heart, or other things that could happen, and sometimes it could be something as simple as heartburn that could be just presenting in a very atypical way. So I would never let it go under the radar. I think it's always good to mention it. And even if you do get those generic answers, and even if you are frustrated, it's just hard because doctors never want to miss something catastrophic.
Wow. Fantastic. Next question comes from Alexis, and her question is, what's the best way to manage the emotional stress of sarcoidosis besides the other medication? And if with medication, what would be the best route without extra side effects that would possibly interfere with other sarcoid medication? Wow.
Well, I know, I'm telling you.
Want me to read that to you again?
No, I think I got the theme there, but, I'm going to say this, and I mean it. I think, the best way to treat the stress and everything you're going with is the Life and Breath Foundation. And I'm not just saying that because Sean's looking at me. What I really, tell my patients is that, sarcoid, I don't know if anywhere ever knows this, it is an orphan disease. And an orphan disease means that there is around less than 200,000 cases in the United States. And I just want everyone to realize that when you have sarcoidosis, my theme is always, you are not alone. And I really mean that. And sometimes you may feel that you're alone. And the way to prevent that is, talking to family, talking to friends. And the most important thing is support groups. And, I'm so fortunate that I have a support group here in Los Angeles. That, I think they like me. they always invite me to come and hang out with them. But, I think that you need to have people to, to understand what you're going through. And I think that many of my patients, I always refer them to the local sarcoid groups here. There's always, even though sarcoid is so individualized, no one presents the same way, there are common things that you could understand. And I saw today when multiple people raised their hand. So my answer is always going to be talking about what's going on, finding people who are going through disease. And the sarcoid groups out there are so awesome. And, I know this video is going to many of them. And I just wanted to say that I'm sorry if I don't get, I've been invited to go hang out with so many cool people, and they do these 5K runs. They want me to go down there, and I don't get a chance to do it because I'm always so busy. But, the people who do these groups are just so amazing. And Sean, I really just say that I really feel the love and the passion from you and your staff. So I think just by showing up to this, that's the best answer. I know she was also looking, the question was like, what are some other things to do? I would be a little bummed out if I would say go get some medications, because that's not what I really believe in my heart. My wife, has a saying, and I kind of stole it from her. She says that when she talks to her patients for rheumatology, she truly believes no one wants to be on lifelong medications. And I think that's true, and I think that really carries over to sarcoid patients that, it's ironic we're having a medication talk right now, but I really feel that none of you out there want to be on these meds. So I don't want that carries over to anxiety. Sure, you could go on meds, but I think being part of this group right now is the best medicine.
Awesome.
Mhm.
Well, Dr. Raj, let's see if we can get to 3 more questions. There's a lot
Sure,
out,
that's it.
but
It sounds like a deal. I could do that.
we'll work hard to get these answers back out to everybody. If not, post it on our website or
Okay.
our social media platforms. So let's see if we can take 3 more.
We could do that, Sean. Sean,
okay.
for you, I could do anything, dude.
Fantastic. Greatly appreciated.
No problem.
Let's try a question from Yvonne.
Okay.
Do you send a CT over X-ray for lung sarcoid? X-rays are normally clear, but still have chest pain and difficulty breathing.
Wow. So, I mean, I have to say yes and yes. You know what I mean? I think when I'm teaching my medical students, you know, I always say you have to do simple things first. And when it comes to imaging the chest, you know, as a lung doctor, I would say, of course, X-ray first. But as Yvonne, you know, pointed out, you know, X-rays are just not detailed enough. You know what I mean? So what I feel in my sarcoid patients, especially if they're having chest pain, that what are some things I might do beyond just a simple CT scan? I may give you something called contrast. Now, why would you get contrast when you're getting a CT? One reason could be looking for something called a pulmonary embolism, a PE, which could be a clot in the lung. And I'm sure many people have heard that word before. Sometimes I would give contrast because I want to know what's a lymph node or not, because of the fact that many sarcoid patients have lymph nodes. So I would say if one of my patients was having chest pain, I will always say rule out the heart first, make sure it's not things like heartburn. But if I really want to give a very all-inclusive lung, the Cadillac of lung evaluations, yes, I would consider doing a CT with contrast. But let me tell this to everyone, do not let anyone give you contrast if you have kidney problems, because that contrast can do a number on your kidneys. Good question.
Awesome. Next question is from Angie.
Andy, all right.
She's asymptomatic with lung sarcoid. Primary issues are neurosarcoid. She's tapered down from daily 25 to 15 milligrams.
Yep.
Milligrams, excuse me, of prednisone and 20 milligrams of methotrexate.
Methotrexate. Sean, we're quizzing you today, man. You're making your money today.
Methotrexate, a week. She says, right now my symptoms are pretty stable. Side effects of steroids have been bad. Is it possible to come off them completely, or would you likely add another med?
Oh my God, such a good question. So, you know, my overall theme is that I want to get everyone off prednisone as quickly as possible. I always teach my med students, it's easy to start someone on steroids, but the hard part is, and many of my people listening today, is getting you off the steroids. And one of the reasons is fatigue. Who's got fatigue out there? I don't think there's enough hand raising going on, you know? And oh my God, it's blowing up. I got it. You know, and as you actually, you know, taper off the steroids, that fatigue kicks in, which is just, it's hard. It's hard. So back to really addressing the question is that, you know, when we talk about the prednisone, you know, I think everyone here is going to know how much I love my wife, because what does my wife say is that, you know, 2.5 milligrams of prednisone for a rheumatologist is 2.5 milligrams too much. Because, you know, when we talk about all those side effects we went over early in the presentation. So it sounds like, you know, the management you've been having is outstanding, because they put a medication on to help you taper off the prednisone. They're maximizing the dose of methotrexate. I even said during my presentation, I kind of like a 20 milligram, you're on 20 milligram. And so one of the best things that could happen to anyone with sarcoid is that, hey, we give you a steroid burst and we could taper you off, and hopefully you go into what we call remission. But most patients with sarcoid, their clinical course is exacerbations where it flares, then it goes into remission, then it exacerbates. And we sometimes keep people on a methotrexate-like drug to prevent these exacerbations, because when you exacerbate, it's called acute sarcoid, which means you get steroids. So I think that, you know, in this specific question, I would try to taper down the steroids as much as possible. And sometimes it's, you know, when you talk to your doctor, you may need a very slow taper. So I'm giving all my wife's secrets away. I feel like she's going to really get me on this, dude. So what, sometimes, when we taper down prednisone, they come in 5 milligram pills. I think many people are familiar with that. So we taper it because we do what's convenient. We go 40, then we go like 40, 30, 20. From 20, we go down by 5s. But sometimes you may need to taper by 1s, by 1 milligram pills, because sarcoid people are, it takes a while. You have to be very patient. And one of the biggest mistakes I always do is I taper too quickly. You know what I mean? So easy up on the taper, talk to your doctor. And like I said, if you're in a good place, the thing is, you mentioned something about nerves, that leaves a whole opening question. Are we talking about the central nervous system, the peripheral nervous system? All these things factor in. If it's the central nervous system, meaning up here in the brain, I really do keep my patients on lifelong immunosuppressions because, trust me, it's so horrible when sarcoid's in the brain, the heart, or in the eyes.
Yeah. Excellent. Thank you, Dr. Raj. And the last question comes from Jennifer. And Jennifer wants to know, what supplements do you suggest taking to help boost the immune system?
Everyone's been asking me that question just for COVID in itself, you know what I mean? But, I'm going to say this, is that, I truly feel that taking any supplement beyond the recommended daily amount, really, there's no evidence about that. I think some unique things out there right now, and things I'm glad to be brought up, is vitamin D. It's so important to have appropriate levels of vitamin D. And even here, I'm in California, and it's pretty sunny all the time here. Trust me, people are still vitamin D deficient. So it's very important. Many people have been asking me about vitamin C and zinc, in the medical ICU, because I am an ICU doctor. We have studies ongoing about vitamin C and zinc and helping out with the immune system when you have things like sepsis. I know there was some data about that for COVID-19. But once again, in what context? You know what I mean? Like, I know that some people, when they feel a cold coming on, they want to take a little extra zinc or some vitamin C. There really isn't any harm in doing that, but I wouldn't just load myself up with it to an extreme amount. Same with vitamin D, which is why it's important to have a doctor kind of manage your vitamin D, because there is a certain point where you could get vitamin D toxicity, though it's not, very common. But I would say the take-home message is that, I always try to be very open, and I think I've been learning so much because many of my sarcoid patients always ask me about something they read about or an herbal supplement. And I always compliment them that you're telling me, because I am more worried about drug-drug interactions, what's going to happen, if it's going to affect my therapy. So always be honest and ask, but I don't believe in anything that's beyond the recommended daily amount. But if you're someone who just wants to take a little vitamin C or zinc before you hit a cold, you're going to be okay. I think that's going to be just fine.
Awesome. Dr. Raj, could you show us the last screen of your lovely wife and how to connect with you on social media?
Yeah, so everyone, I know I talked to her about her quite a bit. Well, this is me. This is how much I love sarcoid every year, in April. I am so proud to do things for sarcoidosis awareness. This is my wife, Michelle, and we're behind the green screen because we both filmed something for sarcoid together. My wife is a little more shyer than I am, but definitely the strongest woman in the whole world. I love her so much, and she leads all this talking to me. This is my Instagram over here. Please follow me on Instagram, Dr._Raj_. And I can't say thank you enough to the Life and Breath Foundation and to Sean for inviting me. I hope I really can meet everyone soon. I hope you enjoy this. I gave it my all. I'm drinking because my throat's getting a little dry on the side. But I hope I got a chance to answer all your questions.
Yeah. Dr. Raj, thank you very much. We greatly appreciate you sharing your expertise and knowledge on this very important subject for a lot of the different patients and the family members out there. You're a champion for sarcoidosis awareness. We greatly appreciate the badge that you take on for all of us and the communication and information you shared this evening. What we wanted to also do is thank all of the individuals, attendees that joined us tonight. We appreciate your support and interest in sarcoidosis awareness, the Life and Breath Foundation. We will have another speaker on September the 10th at 7 p.m. Dr. Benoit will be with us talking about nutrition for health fundamentals of healthy eating. To register, you can go to www.lifeandbreath.org to register. Again, we greatly appreciate everyone for joining us. Dr. Raj, a big thank you to you. We appreciate it. And thank you to all and good night.
Bye, everyone. Thank you, Sean.